voice cases as the need arose. Mostly, I'm working with little ones, school age, with vocal nodules, and who are so trying to retrain how to use more healthy alternatives to vocal abuse, and learning how to do better breathing and sort of more of a flow to the vocal voice as opposed to a pressed voice or a squeezed voice. Recently, I evaluated a singer, and I didn't have enough knowledge that I felt comfortable working with her. And so I needed to refer her to a speech pathologist with a background in vocal performance and singing. And I just thought, I'd really like to learn more. So
good. Well, welcome.
Thank you.
There are a lot of us who are singers here, which is exciting. Yes. And feel free to use all of us as potential teachers of things that you might want to know. And certainly today we're going to talk about singing a little bit, just because there are so many of us who are singers who probably, well, I know, Rachel, you're already a singing voice specialist, but just so that you have some ideas about working with singers too.
I mean, I used to sing professionally myself when I was in my 20s, but I can't say that I ever really got good training.
Okay.
So that being said, I feel like I have a lot to learn in terms of the anatomy piece, the singing piece, and sort of molding it all together.
Okay. How does everyone else feel about anatomy and physiology? Good.
Okay. I think I would have said last time, oh yeah, I'm pretty familiar with it. And then you got into the nitty gritty and I went, oh gosh, I haven't really dissected all those little muscles and all those little connections. So I really appreciated that kind of come back to reality. No, you don't really know it.
Well, I think it's so quickly covered a lot in voice disorders courses because there's so much to cover. And it's like, okay, here's the larynx, you've got retinoid cartilages, vocal folds, vocal processes, you know, all of this, and you basically are memorizing body parts. And it's really not something that, at least when I was in school, and I went to Wisconsin, which was a big voice school, I didn't feel like I ever felt like I understood fully until I started working with Bob Sadeloff and Ingo and looking at models, and that I really kind of absorbed and understood the physiology. And, you know, I think it's always good to just to revisit those things that we learn early on, and then we get distracted by so many other things, especially in grad school, because you're learning not just about voice, even though you are interested mostly in voice, and this was my total situation, that, you know, you're doing artic and oral rehab and aphasia and, you know, swallowing, all these things that are just like, oh. So let me just double check and make sure no one else is waiting in the wings here. All right. Well, we're having a nice little small group tonight. That's awesome. So I'm going to just get started because I'd like to do the presentation and then give us some time to really work on practicing the therapy technique. So I am going to share my screen. And can you see the screen okay? Is it showing the slideshow?
It's showing not in presentation mode.
Okay, thank you. How's that?
Got it.
Got it. Okay, perfect. So as you know, we're going to do muscle tension dysphonia and inhalation phonation. This is obviously a really extreme case of muscle tension dysphonia, but not completely uncommon. This would often be somebody has very little voice because of the squeeze factor. But I put it on here for effect because I just think it's a really awesome depiction of muscle tension dysphonia. In the traditional sense, it is characterized by excessive muscle recruitment. And generally, it is a diagnosis when there isn't another obvious diagnosis present. And this kind of muscle tension obviously is severe, but even in milder cases, it results in incorrect vibratory patterns of the vocal folds and an alteration in voice production. And so these patients are really at higher risk for vibratory edge injuries because of the increased force on the vibratory edge. So MTD traditionally is a technical term for stressful or strenuous overuse of the voice. And it can exacerbate an existing problem for sure, or it can cause a new vibratory edge problem, phonotrauma, as we would consider it. And then, a lot of times the primary complaint is pain and fatigue and loss of range, inability to use their voice the way they have in the past. But you see even singers, professional singers with muscle tension dysphonia, and they don't look like this, but they have significant loss of voice. So I would say this would be something to really be aware of, because without mediation and treatment, they can have nodules develop, or a unilateral vocal fold cyst from the trauma, vocal fold hemorrhage, or even a vocal fold tear. And vocal fold hemorrhages and tears are the two situations in voice that you'll encounter where you need to have them be on complete voice rest. So if someone presents with a tear of the mucosa or a hemorrhage, they need to stop phonating immediately for at least 48 to 72 hours. And we don't generally have the luxury of seeing these patients at the early stages, unfortunately. So a lot of times we see them with hemorrhagic polyps, or a little bit of immobility of one of the vocal folds where the bleed was, or where it's resolved. So it becomes a more challenging case then when you have some scarring or some stiffness. The things that you look for, and how many of you are experienced in strobes or flexible endoscopy? Rigid or flexible? None, no one. Okay. Did you all see the course that I posted on the Facebook page? The group page?
Yes.
The confidential the Confident Clinician, I think is what it was called. They do mentoring with and teach you how to do strobes, I think via Zoom. So it's not hands-on, but it teaches you a lot. So that's something to consider. So just making sure everyone knows when I'm talking about the anatomy, this is all making sense to you. So you have primarily, I would say every case of muscle tension dysphonia has increased compression of ventricular folds. So you're not seeing the full course of the true vocal fold, particularly laterally.
Kate, can they actually come in and touch and and start to vibrate themselves?
In severe cases, yes. In fact, I had a patient years ago who had somehow learned to use his ventricular folds for phonation. And so he didn't even use his true vocal folds any longer, which was quite an interesting case. And we did help him, but man, that was a tough case because he was really good at the ventricular phonation. You'll see increased tension in thyroid muscle. There's an imbalance of intrinsic laryngeal muscles and the extrinsic laryngeal musculature. Increased compression of the true vocal folds during phonation. Imbalances, I think that's kind of talking about extrinsic laryngeal muscles again, but specifically scalenes, SCM, the masseter, tongue base, those kind of things. And what we talked about last time was elevation of the larynx and disappearing of the thyrohyoid membrane space. Big, big, big deal in muscle tension dysphonia. I would say almost all patients who have MTD have that as well, which is why I started with that last week. And then also the narrowing of the pharyngeal cavity.
Okay, can I ask you a quick question, actually?
Absolutely.
So I actually do strobes more flexible than rigid. I haven't done it in a long time. However, I had a patient recently whose arytenoids were crossing. Would you see that in like a significant muscle tension dysphonia?
It depends on the patient, really. Sometimes the arytenoid cartilages are really unique individually. So you wouldn't necessarily see a crossing of arytenoids and think that's specifically MTD. It could just be their own anatomical variation.
Okay.
But I would say that's a possibility of something that you might see with extreme muscle tension present, because it impacts the whole mechanism.
Yeah. So I was just having a hard time because first I thought the arytenoids was the right arytenoid was displaced.
Okay.
And thought perhaps they needed a procedure or something, but the ENT just felt it was more muscle related, but
Okay.
I don't know if I agreed. So I just wasn't sure.
Did you do a sniff test?
I did.
And how did they respond?
I mean, in terms of more like abducting, he was able to, they looked pretty symmetric when he abducted.
Okay.
But then as soon as he was adducting, the right one crossed pretty far over midline.
Okay. What else might that signify, do you think?
Would it be like paradoxical motion or?
Not necessarily paradoxical, but maybe there's a unilateral weakness that the right side is overcompensating a little bit.
True. Yes. And I think he did have a slight weakness now that you just said that. Okay. So that makes sense.
But I think it's fair to say that you might see that in muscle tension dysphonia without an underlying weakness. But when I see one side kind of crossing over the other, that's definitely something that puts my radar on, hey, maybe there's a subtle asymmetry, maybe a little paresis on one side.
Okay. Sorry. Thank you.
No, I want you to do this. So thank you for chiming in. All right. The other things, because of the laryngeal height shift, there's a restriction in the movement of laryngeal cartilages, and that affects their ability to access their super low range in particular, but also sometimes the upper range as well. Always there's a complaint of laryngeal tenderness that intensifies with voice use. So they just reach a point where they don't want to make another sound. You'll see muscle tension in the head and neck musculature as well. So it's not just here, but maybe they have a really tight head posture. So if if you were in person with them and you just felt their head and tried to move their head, it wouldn't move easily. That's very common with muscle tension dysphonia. You'll see often a diminished mouth opening. In fact, I was working with a patient today she's a singer, but she was really like almost not moving her mouth. And I asked her about it, and she thought it was that she thought she used her mouth more normally behind a mask. But when she took off her mask to sing, she felt like she didn't want to move her mouth. It was really interesting. So I don't know if you'll start to see more of these kind of syndromes with our whole mask wearing, but I thought that was really interesting. And she's definitely has muscle tension dysphonia. Then you'll also see postural changes in these patients. So a lot of times the rounded shoulders, maybe no neck because the shoulders are up and rounded. You'll see very often a forward head position. And then, you know, obviously the muscles that support that will be tense just to hold the muscles, hold the head in that posture. Tongue and jaw tension generally go hand in hand with MTD. And sometimes it's so bad that they get referred pain in one of their ears or both. Decrease in vocal range and power because the muscle tension is basically dampening their voice production. And the fatigue is always there. Increased effort because of, yeah, it's like their built-in resistance against their own voice production. So this is why often we'll see in a laryngeal finding in a strobe that they have little soft swellings in the mid-membranous part of the vocal folds, which the doctors will probably say, you know, pre-nodular. But if they don't change their muscle tension patterns, they probably will develop into actual nodules. So, and then Lauren, this is just exactly what we were talking about. So you can also see it as a response to a paresis or an underlying weakness. And so it's like the body's way of kind of limping and to kind of overcompensate for the side that's not working well. And you'll see that on obviously the contralateral side. It's also possible to have MTD from a change in the vibratory edges. So if you have somebody who's got a lot of reflux or allergies, they sense, even though we don't have pain sensors on our vocal folds, they sense the changes on the vibratory edge, and then they start engaging muscularly to overcome that, or even overcome maybe a little bit of change in the vocal quality. So as a response to that, and you see that a lot in singers. Singers don't like to present themselves in any way other than fabulous. And if there's a little bit of a roughness in the voice, they're beautifully talented at messing to kind of clear up that sound. But that obviously reinforces the irritation at the vibratory edge and can lead to a more permanent pathology. So, and a lot of times you'll see, hey, Dave. I've got my friend's Bernese Mountain Dog with me today. You will see a muscle tension happen because they don't have any kind of support mechanism in place. And this is for speaking and singing. I see this a lot with teachers, with people who are high function professional voice users. And I think that our profession would really do teachers a favor by having some kind of specific training for teachers. We did research for occupational voice, and there is no training for teachers on voice production. You know, they're so vulnerable, and they're also vulnerable to getting sick. So then they're oftentimes speaking with a viral infection, and I feel for that population so much. So, and then also, well, I think I talked about this a little bit. So the irritation from an infection or reflux. All right, good. Sorry, I'm not really reading my slides. The other thing is you'll see MTD happen because of postural misalignment. And I think Sarah was an Alexander trained clinician as well, so she could appreciate this. But if you ever end up working with singers or even voice clients who wear high-heeled shoes and stand and talk and give presentations, that might be an easy fix for them as far as postural changes, because they may not be able to connect to their breathing or support mechanisms well if their pelvis is tilted. Another singing thing specifically is if you have performers who sing with amplification, but they don't have good feedback, they don't have a good monitoring system, or they don't wear inner ear monitors, then they end up pushing and really ending up with, risk for injury and pain and fatigue. But stress can be in and of itself a reason for people to have muscle tension dysphonia. So if you've got physical stress, relationship stress, work stress, COVID stress, that obviously manifests in muscle tension. That's just how our body responds to stress. So these are all things to really consider. Also, anxiety and depression, not just stress. And you might have a patient who has an eating disorder, and that can also cause MTD because they don't have the physical strength to support their voice. And the last one that I have on here is pelvic floor dysfunction. And I am going to do a pelvic floor class coming up probably next month or this month. Well, no, I guess it's still January, next month. So how much have you learned about doing a comprehensive clinical case history? You're feeling pretty good, Susan?
Yeah.
Rachel, you're obviously doing it. How about you, Lauren?
I feel okay about it. I mean, I'm not sure. I think I feel confident about it. Yeah.
Okay. So what kind of questions would you be asking your patients with MTD to kind of get to the bottom of what's causing this muscle tension? Let's just assume that the ENT said, the cords look fine. This is just muscle tension dysphonia.
Mm-hmm.
What would you want to know?
I would want to know, are they in pain and where do they feel the pain? Like, do they even have a sense of kind of where in their throat or body, whole body area that they are feeling any kind of pain?
Okay. Good.
I guess I would also want to know if they feel fatigue or pain, and what time of day.
Good. That's an important question. Lauren O?
I often ask what their vocal demands are throughout the day. I tend to ask also some open-ended questions to get more information from them versus kind of guiding their answers.
Good. Do any of you have like a questionnaire that you give your patients or that you follow when you're doing an intake assessment? Oops, Lauren, I can't, or not Lauren, man.
Oh,
Rachel.
I do follow a set of prompts, but one of the questions I always ask is it different in your singing voice than your speaking voice? And where is it, like, how is it different?
Okay. So you're talking pain and fatigue, or?
Yeah. Do you notice that you're hoarse in your speaking voice, but you're not having the same issues in your singing voice, or is it just in your singing voice or in your speaking voice?
Okay. Very good. And let's see, did we lose somebody? Oh, there's Mercedes. Okay. Mercedes, do you have any input on that?
In acute, if we have time, we're encouraged to do the VHI, but in outpatient we always do. But acute, that's like, besides like just informal readings, VHI is the only thing
Okay.
have us do.
And what do you guys think of the VHI?
I find it mostly helpful in getting people who aren't aware of their voices, like who aren't professional voice users, to suddenly become aware of how much they're affected.
Yeah.
You know, like a teacher who would be like, oh, you know, my voice is I get a little bit fatigued or whatever. And then you give them VHI and they're like, oh no, it's really bad.
Right. Do you all have copies of that?
No.
Okay, I'll get you a copy of that. Do any of you have the singing voice version?
No.
I might.
Okay, I'll send you that too.
Thank you.
Thank you.
All right, so these are the top ones that just kind of came to my head. How long have you been experiencing voice difficulties? So has this been going on since the show they were in, or the first week back at school, or after a trade show, or is this something that's gone on for, you know, months or years? So that tells you a lot about the patterns that you might experience in therapy when you're doing the treatment part of it. Precipitating factors. And this is important to ask because maybe they did have COVID, or maybe they had a virus, and then their voice never really recovered after that. And maybe it's just getting progressively worse since that precipitating event, or maybe they had the death of a parent or a friend or something like that. That's a stress-induced muscle tension dysphonia. So those are the kind of things I think always is a good idea to ask, you know, any precipitating factor. And then also in their own words, how would they describe their vocal challenges? Because I think it's always better coming from them. And then you can ask questions after they're describing their challenges, and dive in a little bit deeper. But it's always good to hear kind of from their perspective what's really frustrating to them or bothering them. And then also in that, what would they like to change in therapy? So any other significant medical history is always a good idea, including illnesses, surgeries, medicines, hormones. And a lot of times they won't even think about hormones or surgeries as an important thing, because if it wasn't on the voice, they don't think it's necessarily relevant. So, and obviously, if they have general anesthesia, the vocal folds are part of the surgery. So really important. And then obviously psychosocial questions. Are you, I think almost all of the medical histories that I've come across ask marital status, which I think is a little bit outdated. But, do you have any stress at home or work? I mean, you can be more broad in your questioning, but I think it's relevant. Also, things like allergies don't necessarily come up on the radar of the patients. So if they have allergies, how do they treat their allergies? So maybe someone told them to take a Zyrtec every day, and they've been doing that for 3 years. And now they're super dry. And that can cause MTD, because it takes a lot more effort to initiate vibration of the vocal folds if their cords are dry, which is also why I ask general questions about their vocal hygiene in general. So are they hydrating systemically? Are they doing any steaming? Do they drink caffeinated beverages? How many alcoholic drinks a week? Do they smoke? And in Colorado, do they smoke weed? I mean, there are other states now in the US that are legalizing pot. So it's definitely something to ask, and you can say, if they don't want to say, you can just tell them that you won't put it on their medical record, but you need to know because it definitely impacts their voice. And sleep and exercise and all of those things really matter. So
Do you do a general reflux question in your case history, or only if they're coming in with indication of that?
I mean, I think in general, I will have already seen the strobe of the patient, and they'll have already seen the doctor who manages the reflux medically. And some people will definitely have symptoms of LPRD or GERD, and some won't at all. And in fact, they need convincing that they even have reflux. So, but, if you have somebody who eats late at night, drinks red wine every night, you can kind of create sort of an understanding of the profile that maybe there is, if there isn't reflux, that there might be, and, talk to them about it. But yeah, reflux is definitely an ever-present issue in voice patients. And it's worse as you get older.
Mm-hmm.
Because really, I think until you're about 25, the LES, the lower esophageal sphincter, is in pretty good shape. But after 25, it starts to become less strong as far as sphincters go. So, but yeah, that's a good question. I had my first clinical experience outside of grad school in a very high profile professional voice office with Bob Saddleoff, and he had like a 14-page questionnaire.
Oh.
And I'm not kidding. And this is back when they didn't have an online presence to fill out the questionnaire online. But even if I have a written questionnaire, I'd always rather ask the patient the questions myself. And it's actually why when I was working at the University of Colorado hospitals and clinics, I said I wouldn't do an evaluation if it was a 30-minute slot.
Mm.
That I wanted an hour for an eval. And the payment, the reimbursement is so much more for an assessment anyway, that if you're trying to do an assessment in a half an hour for a voice patient, it's really hard.
Mm.
How much time do you guys generally have for assessment?
I have 2 hours.
Oh, okay. That's great.
Mhm.
How about anyone else?
1 hour.
An hour? Okay.
Yeah, 1 hour for me.
Rachel?
I'm not doing them yet, so.
Well, I only see people privately for that at this point. So really, yeah, I can't even imagine doing it in a half hour. There's just way too much. And I agree with you. I need to talk to them, least of all, because then I can hear what's going on.
Right.
You know?
Yeah, you get so much information just by talking to them. And then they're not as self-conscious, like you're not doing and thinking about their voice quality, but you really get a lot of information about their hard glottal attacks, their vocal fry, the overall quality of their voice, all while you're getting really important information. So I highly recommend that. So how many of you do oral mech exams for all your patients?
I didn't know about oral mech until I went into graduate school, until I went back for SLP school. And boy, I wish I had learned to do that. That would have made my life so much easier for the past 10 years.
Right. Yeah. Susan, how about you?
So right now I'm not working with voice patients, but in schools I can do an oral mech on kids. Although now with masks it's very difficult, but I can I could do it.
Hard to do an oral mech with a mask on. It's so important to do. so important to do. Even if you think, oh, this is a singer and they're fine, everything's normal. I had a patient who is a singer and a professional tennis player, and she came in and I did an oral mechanism exam, and she had soft neurological signs of ALS.
Right.
And I would have missed it if I hadn't done an oral mech exam. And it's not something that I anticipated at all, but she did end up having ALS. And so I was like, it just reminded me that no matter how confident I am that this person has a normal mechanism, I don't always know, and never assume.
Kate, how did you go about kind of encouraging her to maybe seek more information from the signs that you saw?
I was just honest with her. I said, I see fasciculations in your tongue, and there are other, that was the main presenting sign for me. But also the fact that she was a professional athlete. My office was in the laryngologist's office. And so I brought him in to talk with the patient, and they made a plan with a neurologist for a full eval. And, you know, I mean, I just said, this is one sign. It doesn't mean that this is what's happening with you, but it's significant enough for me to say, let's rule it out, because it's a big deal if it is. I didn't say that to the patient, but you know, I just was really honest with her, because that's how I think we need to be.
I'm sorry, you faded out for a bit. What were the signs that you had seen on the tongue?
Fasciculations. So when you're doing an oral mech and you have them stick their tongue out, the tongue looks like it's, I mean, I can't show you because my tongue doesn't have it, but it moves erratically. And it's not just like a shake of it, like a spasm tongue. Like when you see patients who have a really tight tongue, if they stick their tongue out, it'll shake a little bit. But this was, the tongue was moving.
Wow.
It was really interesting. And I'd only seen it one other time, and it was like my first year as a practicing voice clinician in Philadelphia, and it was a soap opera star. And the same thing, I saw it, grabbed Dr. Saddleoff, told him, and then he ended up getting into the neurologist that day, because we had a neurologist partner in the team, and he was diagnosed that week, and he actually brought it into his character on As the World Turns. So it was just, again, one of those life-changing moments where you have to make that kind of diagnosis. And I didn't obviously make the diagnosis. I had Dr. Saddleoff refer him to a neurologist, but and I didn't tell him at the time what I thought. I just grabbed Saddleoff right away because I was such a new clinician. I'm like, oh my God, this is not happening to me. And it was really sad to have to see this, because it was somebody that I, had watched growing up with my mom. We watched soap operas together. But he took the news, with, I don't know, like just in the most humble manner possible. And he chose to use it as a tool to educate people about ALS. And I thought that was just amazing. So obviously when you do the oral mech exam, you can see tension in the tongue, both from a shake point of view, but also if the patient has a lot of tongue tension, you'll actually see the outline of the teeth scalloped into the edges of the tongue.
Ooh,
So that's something that you can look
wow.
and find really, really quickly. We talked about the laryngeal aspect of it last week, but also jaw. If you've got even soreness in the masseter or pain in the jaw joint and referred pain in the ear, that's obviously a jaw manifestation. Anterior, posterior neck, shoulders, we talked about, upper chest, even a depression of the whole sternum, and tension in the abdomen and pelvis, and that you'll see like a gripping of the abdomen, and also you'll notice this more standing, but a tension or gripping in the pelvis as well, or a tight glutes, really limiting the pelvis. And I always evaluate their breathing, even if it's the most professional singer that you know, like Adele. I always evaluate their breathing, because it can be a big source of muscle tension. So if they're costally breathing or their shoulders are rising, there's no way that they're tapping into abdominal support at all. Check for head alignment and locking, like I was saying. Like if you have the patient in front of you, just you know, when you're doing the oral mech exam and they're already used to you kind of touching, then just kind of try to move the head. And if it's locked, you know that there's a locking, you know, from the upper traps back here down to the scalenes, SCMs, probably a hyoid complex of muscles as well. And then you can also even sometimes see a jaw jutting forward. And this might even worsen with phonation. So, you know, have them sing or do like a pitch glide, even if they're not a singer. So I am of the school that I like both rigid and flexible, if possible. Now, you may not be in a situation where you're doing the strobes. I think it varies based on who you're working with. But ideally, you have the opportunity to have at least the flexible scope so you can get dynamic speech and singing if you're working with a singer. Otherwise, it's really hard to tell what they're doing muscularly, because the head's forward, the tongue's out. You know, you've already really changed the whole postural aspect of voice production. And then you also have the gag reflex of the rigid, that if you only have a rigid, it's great for the magnification of the tissue and looking at blood vessels, and, you know, looking at the benign vocal fold lesions. But the flexible is so important to really see, like, technically what they're doing, how much muscle tension is involved, what the ventricular folds are doing, without altering the anatomy. And if you are working with a singer, it's so important for them to do what is challenging for them while they're having their exam. So if you're I don't do as many strobes as I used to, because I don't have my office in the laryngologist's office anymore. So I will go in and he will do the strobe, and I will be with the patient and ask him to do the certain things, because otherwise he's just in and out, and I don't get all the information I really want. So they need to sing something. They need to go through the part of the range that's challenging for them. And you need to get a really good idea of what's happening with their voice. It's also an opportunity to do a little trial therapy. So I try to be present for the strobes whenever possible. So we talked about this a little bit in our pre talk, but I really would just assume that MTD is secondary. Even if it's an ENT that says it's a normal exam, if they're not a fellowship trained laryngologist, they most likely will miss subtle changes in the mechanism. They're not trained to look for the things that the laryngologists are trained to see. So, and the only time that I would say it's 100% MTD is, when you have kind of a traumatic event or a traumatic illness, and the person loses their voice completely, and then they don't get their voice back for months. And usually that's what I consider traditional muscle tension dysphonia. We talked about all of these already. So how many of you have worked with patients with spasmodic dysphonia?
Oh, a long time ago.
Okay. I added this to our talk today because MTD can mimic ADSD, adductor SD. So if you've got, especially severe MTD. So if you have a patient who's really tight and they can't phonate, it sometimes sounds like somebody with adductor spasmodic dysphonia. So in your handout and in the slides tonight, I'm going to include differential diagnosis. And it's just a quick little way of determining, is this really MTD or is this SD? Especially if you see the person before they see a laryngologist or an ENT. And that sometimes happens. Sometimes you get a referral and they haven't had an exam with a MD. So basically with MTD, you're going to have pain. You're going to have an exacerbation of pain and fatigue with voice use. You're going to have multiple sources of muscle tension. So, maybe they feel it here, but they also feel it in their neck. They feel it in their tongue and their jaw. Usually when you see patients with learned adaptations following an upper respiratory infection, those are generally muscle tension dysphonia, or compensations for an underlying pathology, or even compensation secondary to reflux. But spasmodic dysphonia is really a double onset, primarily, well, more women than men are diagnosed, but that's sort of irrelevant. It's very task specific. So with adductor SD, you have a strained voice quality, you have voice breaks in vowels, you have kind of a frustration along with voice production. With abductor spasmodic dysphonia, it's more of a breathy profile, difficulty with going between voiced consonants and voiceless consonants, and vowels in particular. And it's really a neurologic vocal dystonia. So spasmodic dysphonia will improve with laughing, crying, singing, and sustained phonation, the adductor. And sentences with all voiced consonants is much harder than a normal profile. Sentences with mostly voiceless consonants are much easier for patients with SD. And with abductor, voiced consonant sentences are much easier. And you'll hear that breathy break between voiceless consonants and vowels like pa. So I'll give you these in your notes, but the voiced consonant task is all voicing. Early one morning, a man and a woman were ambling along a 9-mile lane running near Rainy Island Avenue. And so this is much more difficult for someone with adductor spasmodic dysphonia because because the voice gets just too tight without the the break of voicing that a voiceless consonant provides. People with MTD, their voice is consistently the same no matter what kind of tasks you give them. It doesn't improve with, it might improve a little tiny bit with singing, but not really. So the voiceless consonant task is, he saw hefty horses cross 50 or 60 steps in front of his sister Kathy's house. You know, just an easy one. I sometimes use the voiced profile to also check hard onsets. So if you're assessing hard glottal attacks. I also use Marvin Williams. Have you, any of you heard of Marvin Williams? I can include that in your notes as well. These are just really easy assessment tools that you can put in your folder and just have with you for, you know, when you have patients who you're not sure about. Sometimes the spasmodic dysphonia patient is really clear, and sometimes it's not. So it's good to have a way of knowing. The other, yeah.
Sorry, sometimes I'll get pulled into a physician's office and they'll ask me like, oh, do you think it's this or this? So I'll sometimes have the patient count either from 60 to 69 or 80 to 89, and I'll listen and I'll ask them which one felt harder. That's just like a quick one I usually go to too.
Perfect. Yeah, I was just getting to that. So I love doing the 80s and the 60s series because that's, again, a really quick profile. 80s series is much harder for an SD patient with adductor spasmodic dysphonia. You also notice that there are more breaks with repetition of voice consonants, like w or we versus p, or t, or key, those kind of things. But yeah, the 80s series and 60s series, 80, 81, 82, 83, in case you were wondering what that means. 60, 61, 62, 63. For an adductor, 60s is much easier. With MTD, you have phonotary breaks. They're not as often. And their sustained vowels are commensurate with their connected speech. It's not a big difference. And there's no difference in their profile between voiced and voiceless consonants. So they could sing, they could speak through both 80 and 60 without any marked difference. Yeah. Once again, Lauren, you're right on right on the ball. With ADSD, also pitch glides are a good little assessment. So the voice improves as they go higher. Also, the voice improves in falsetto counting, like 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, or happy birthday to you, in kind of a higher pitch. And also whispering, like, how are you? How are you? And I don't actually have them do whisper. I have them do light voicing or confidential voice. And then is harder for them than ha, 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 obviously. Again, you won't see that kind of profile in an MTD patient. So it's just important, especially if, I think the speech pathologist often can be a good partner in differential diagnosis. We spend more time with the patients. Sometimes the physician will just say this might be SD, and you do trial therapy as part of the differential diagnosis. So having this little set of tools is really important and easy to just be able to say to the physician, no, I'm pretty clear that this is either AD spasmodic dysphonia or MTD. We don't, voice therapy is not really a good treatment plan for patients with adductor spasmodic dysphonia. I've had a couple of sessions with patients with SD prior to Botox to get them to relax the muscle tension that sometimes is present. Sometimes it can coexist with spasmodic dysphonia. So you treat the MTD part of it and get them ready for Botox. And then it's not uncommon to have a session or two to help prolong the effects of the Botox, but it's not really something that you wouldn't see a patient with spasmodic dysphonia on a regular weekly basis for, weeks and weeks at a time. It's just not, it's not efficacious. And then really quickly, we just talked about a lot of this. 60 series with abductor spasmodic dysphonia. It's much less common, but it's just really basically the opposite profile of the adductor spasmodic dysphonia. An essential tremor is really not something that we can help significantly. I think giving them the same kind of reducing muscle tension or their response to the tremor, improving their flow and their support is about as much as we can do for these patients as well. Has anyone had an opportunity to work with someone with essential tremor?
I have.
And were you able to have any impact on their
Well,
the voice profile?
So one patient, I've had a couple recent, within the last 3 years, I would say I've had maybe like 2 or 3, but one, I felt like we sort of masked the tremor with some techniques, more like easy onset and slower rate of speech, just sort of compensatory behaviors that did help her, but then some stressors kind of brought it back on again. So they are very difficult patients. And same, like you said, I would do like a trial of therapy, 3-4 sessions, and then usually discharge after that.
Yeah, I think that's appropriate. I'm not saying don't work with the patients. I'm just saying this is not something that it would be ethical to continue on for, more than that, more than 3 or 4 sessions, unless they feel like they want to do it for, some specific reason. But, and I say this because I've had experiences with clinicians who see their patients for like 20 to 30 sessions. And without really demonstrating they're making an impact in that person's voice. And I just have a hard time with that. So putting it out there to not do that to your patients. So these are the things I focus on when I do see them for the limited therapy: improving flow, optimizing posture, breathing, phonatory support techniques, all the muscle tension, secondary muscle tension, dysphonia aspects of their SD profile. And then improving the impact of the Botox, so if they know how to support their voice and they can move more airflow through their voice, they're more likely to have a longer window between Botox injections. And that's always appreciated by the patients.
Can I ask about, so when you've got a singer then and who has SD, what do you advise? Because as soon as they've got the Botox in, singing voice is gone. But my experience has been that when they have no Botox, they can still sing. And so then there's this trade-off. So I've never really found a good balance there. What do you do?
So what I do is I work with a couple of laryngologists in town, and the one that I used to have my office in, Dr. David Opperman, he does microdoses of Botox for singers. So it breaks the tremor and the tension cycle, but so they sing a little bit more freely, but their speaking voice is slightly better. I don't know if that's what I would recommend to all singers, but I think if they have a mild case, then I'd probably opt to have them go as long as they can without the Botox. And then, start with small doses.
Yeah, because what happened in my case was then there was a secondary MTD, and so it's you're fighting an uphill battle at that point, and you lose you're living as a result, you know, if you're professional. So I
Right.
felt very lost in that case.
Yeah, that sounds really frustrating. I haven't ever had a professional singer like who's making their living on singing have spasmodic dysphonia. But in general, I am, other than for this particular situation, I am not a fan of Botox. Seems to be a new trend emerging with laryngologists, particularly on the East Coast, and they're using Botox post-operatively, kind of as forced voice rest. And I think I understand compliance issues with surgical healing, but it really puts the voice therapist in a strange position, because now instead of seeing a patient after phonosurgery, like maybe 6 or 7 days after surgery to get them returning to voice use gradually, and now you have 2 to 3 months where they still have Botox on board, and there's definitely a muscle tension pattern that starts to emerge because they get frustrated that they can't use their voice normally. So I don't know how, have any of you had that experience at all? No. I'm not a fan. Because really, like, we can't do anything if they can't bring their vocal folds together, if they can't use their voice at all. But I see them frustrated, and I see them starting to get muscle tension, and it's bad. So just know that it might be out there. So we definitely do circumlaryngeal reposturing. Check the larynx. That's the first thing that you should do with most of your patients. Then even flow phonation obviously is so key, but it goes hand in hand with breathing and support techniques. So what are you guys teaching for breathing and support? Like, how do you teach your patients how to breathe and support?
Laying down to feel where the getting a lower feeling of where the air is. So, and it also prevents the shoulders from going up.
Anyone else?
Yeah, I guess I sometimes do a combination of what you had just suggested, and then sort of leaning against the wall and doing a like that, pulsing. And then I do some semi-occluded vocal tract exercises, straw in the water.
Okay. So when you have somebody with muscle tension dysphonia, it's really important that that you address the muscle tension first.
Oh.
And you can teach your breathing techniques alongside of the muscle tension. But if you don't address the muscle tension, if you have them load their voice, they're potentially going to just increase the pain and fatigue and the symptoms that they presented initially clinically. So that's why absolutely the first thing to do is to work on reposturing the larynx, make sure that that's normal. And I usually at the same time do the muscle tension releases that I gave you in the MTD handout and that we talked about last time. And I generally do start with that and take them through the direct massage release exercises, and then I do the breathing. Because I want them to know that that's sort of the order of importance. And I also, I think it's great for them to experience the low belly breathing. and really reducing the costal aspect of breathing, especially if they're really tight. And you see a lot of that. And we'll go into this more in the pelvic floor class, but if they know how to breathe well, but they don't know how to exhale well, that's a really big deal, because phonation is exhalation. And so you can have these great inhalers where they've got a nice low belly breath, but if you don't teach them what to do after that they're just using elastic recoil, and it's a very inefficient manner of phonating or any kind of voice use. So that's why, my main focus of research is pelvic floor, optimizing respiration and support with specific muscle training, because if you just teach them an inhalation phase, then they don't really know what to do. And in fact, even a lot of singers, if you ask them how they support their voice, they can't even tell you how they do.
I agree. Yeah.
And they think it's the diaphragm, which I'm like, okay, the diaphragm is your inspiratory muscle. So we're not supporting primarily with an inspiratory muscle. So it's an area that I think is really, really so ambiguous for a lot of people in voice, and including voice clinicians. How would you describe it to me if you had to tell me how to support?
Yeah, you're asking loaded questions. That's why I wrote an entire dissertation about breathing. It's so, the research says that what people do and what they say they do are not the same. So when I work with people, I tend to focus on, let's practice quiet breathing. Let's focus on how do you breathe when you're watching TV, for example, versus when we're out doing exercise, because those are different skills. So I think that's sort of the gateway, is to practice the quiet breath. Is your jaw loose while you're doing that? Is there space between your molars? Is your tongue up in the end position on the roof of your mouth? Are you, and then how are you breathing then? And that, I think that's a great way to address MTD also, because if we're reducing the tension in our everyday just sitting still breathing, then it's easier to get at all of the laryngeal issues that might be going on. And then you can talk about, okay, so now when we're actually doing the athletic movement of phonating, we're going to breathe slightly differently, but we've already laid the groundwork in the quiet breath.
That's great. That's really great. Thank you for saying that. My goal was not to ask loaded questions. So obviously I get really passionate about this. And so thank you. Yeah, I think that's brilliant. Anytime we can get the patient to focus inward, we're doing something positive. I find that especially with patients with MTD, they don't have a good connection, mind-body connection. And so you're absolutely right. I think, having them notice their bodies while they're quiet is a really great place to start. And if that means that they have the mental space to check in with their jaw and tongue and posture and those kind of things, you're doing so much in that exercise alone. That's really helping them improve. Getting their awareness is so key. So thank you for that. It's absolutely spot on. And then teaching them, like you said, as they go to something that's more dynamic and less quiet. It is a different kind of breathing but you want them to start moving in the right direction. So getting the more movement in the abdomen versus the chest. Noticing their tongue and jaw, noticing their head, whether it's locked or, you know, maybe it's not free, or as free as it could be, or maybe it gets tight when they go to make sound, but it feels fine when they're just sitting and watching television. These are really important things for the patients to start to consider. And that's good work they can do on their own. But you're absolutely right. Absolutely right. And I do think that if you're seeing professional voice users, having some of this experience in your own body is so helpful to be able to teach it and help them experience it. So we'll talk about this a little bit more with the inhalation phonation, which I like because it does set up the breathing mechanism really well in a natural way. So just kind of go back through this a little bit. Optimizing pitch and loudness is also really important for this population because generally they have a pattern of hyperfunction that's not just muscular, but it's also, you'll find sometimes that these patients are really loud. Or their pitch is high or too high or too low. And it's interesting that professional singers will often use their singing voices beautifully, but sometimes they'll have a complete disconnect for speaking. And so they'll be a lyric soprano or a coloratura soprano, but they come in talking like this.
Oh, interesting.
And I see this a lot in sopranos and tenors in particular. The higher voices tend to overcompensate with the lower speaking voice. But it's definitely something to consider, even when you have somebody who you know uses their voice well in one aspect. It doesn't always translate for both speaking and singing. So I do work with optimizing pitch and loudness and use resonant voice, the direct massage release, yawn sigh. It's an old technique, but a goodie. But my favorite is inhalation phonation. Who here has any experience with inhalation phonation?
I have a little bit.
Okay. So let's get into it. These are the reasons I like inhalation phonation therapy. It does provide a reset, releases tongue and jaw, eliminates pressed phonation, lowering the larynx, widening of the hypopharynx, improving resonance and laryngeal stability, prepares the breathing mechanism. It actually does improve the vibratory characteristics of vocal folds. I've seen it with strobe with patients, and I have them do an inhalation phonation, and then it's amazing. The amplitude of vibration improves and the symmetry improves a little bit too. And it's also working with the coordinating of the diaphragm and pelvic floor for inhalation and phonation. And I know this is a relatively new concept, that the pelvic floor plays a role in breathing or in phonation. So I don't expect everyone to know. When you are learning about breathing in school, is the pelvic floor mentioned at all? No. Okay.
No, no, I didn't know.
All right. So we're going to definitely do pelvic floor next month. So is everyone kind of, or how does everyone feel about their knowledge of what inhalation phonation is? Like if you had, can you make a little inhalation hum for me?
I actually found it kind of difficult and a little counterintuitive.
Yes, I think that's fair. It's the opposite of what we normally do, which is why I think it's a fun way to teach inhalation phonation using an organic reference. So like if you're going to sneeze, that's inhalation phonation, or at the end of a laugh, inhalation phonation, or someone scares you. And like those are organic productions of inhalation phonation. Rachel, were you going to say something? No, okay. So that's generally how I introduce the inhalation phonation. But I find that if you can just quiet it down to inhaling with a little hum and make a little phonation, and then exhaling. And if you are comfortable with the patient, if you've had a little bit of time with them and you've already talked about breathing in the belly, you can cue the belly extension or the rib expansion at the low floaty ribs on that inhalation. Does that feel easier?
So it's an inhale followed by an exhale, yeah?
The reason I like doing that is that we're not really obviously going to have the patient stay in inhalation. So if we can use it as a reset and have it immediately impact the exhalation or the normal phonation, then we're giving them that experience of the release in their normal phonation. So the inhale, and this is fun, if any of you have access to a strobe and you can play with this a little bit. When a patient inhales, obviously the vocal folds open, the musculature that was tense, even with a muscle tension dysphonia patient, releases. And it only tenses again when they go to adduct the vocal folds. So if you do a little inhalation, you get a little bit of contact of the underside of the vocal fold and maybe a tiny bit of the anterior third. And then they release, you'll see the vibratory characteristics improve in the vocal folds really almost immediately. And that's partly why I explored this, because every time I would see somebody breathe inhale, I would see the change in the architecture of the whole supralaryngeal area and lateral ventricular folds. All of that just releases. So if you can get them to do that with phonation and then exhale or it really does immediately release. So I have them do the inhalation hum, exhalation hum, and then inhale hum, exhale hum into vowels, so they maintain that released phonation a little longer. So may, me, mo, moo. And I just picked the Italian vowels because I'm a singer, but they're also pretty straightforward.
So the inhalation phonation is short. It's not very long.
In this example, there's definitely a hierarchy where I will extend the inhalation longer. Does everyone feel comfortable doing that much?
May.
Me.
Me.
Wow.
Oh.
Lauren C, is it feeling better, more comfortable? Or sorry, Lauren G.
Really? Yeah, I'm still working on the inhalation without like sort of having the stridor kick in, you know?
The sound of the inhalation is generally going to be a little awkward,
Mhm.
especially at the beginning of learning it. And if you think cueing your ribs or your abdomen,
Mhm.
or even the descent of the diaphragm,
Mhm.
and then exhaling. There are some patients who I've had that sound like they're taking their last dying breath when they do inhalation phonation. Like it's like, it's really, it's, it's, and so I'm like, please warn your family when you're practicing these so that they don't worry about you. But it's really about the feel more than the sound. And it doesn't have to be very long, especially initially, just enough of an inhalation posturally so that there's a release and a reset. Really, really important.
I found it doing quietly, the inhalation doing, because when I was trying this on my own, I also felt that kind of stridor because I think I was trying to like make a big voice, and then hearing your example, it's very quiet.
Definitely super quiet, very chill. Yeah. So I was going to do breakout rooms, but because there's not that many of us today, we can just do it together. I just want to make sure everyone feels okay with this step before we go on. So then usually I like to add a pitch glide to this hierarchy. So you're going to inhale hum like you did with the regular vowels, but then you're exhale humming into a pitch glide. So and again, you're going to hear in your patients more balance between air and voicing than when the tension can dominate. And if someone has super like severe muscle tension dysphonia, I will sometimes have them do the reposturing as they do this. So because by doing the press in and down, you're reposturing the larynx, but you're also stabilizing the strap muscles so they can't fire as robustly. And I've got my hand right on the clavicle here. And again, a little head movement also can help otherwise occupied or distract those muscles from engaging. How's that feeling?
This is better than when I had been doing this a long time ago, it was think the H to kind of cut that starting so harshly, which engages all the muscles. I like this much better because you're really changing it, how you get into voicing.
Good, good, I'm glad. Anyone else feeling like this is a helpful idea?
When I've used it with singers, sometimes I have them start on vowels. Do you always start with a hum?
I would, when I'm introducing it for the first time, I do. But I move pretty quickly into vowels with singers.
For the inhale.
Yeah.
Yeah.
Um,
And into it. I've been doing it like inhale on a pitch and then do like a descending pattern or, 5, 4, 3, 2, 1 kind of thing. Do you typically, when you do that, do you inhale on the same vowel or do you use a different one? Like
I do.
ooh.
I'll inhale the same vowel. Like if I'm doing ooh, ooh, or whatever vowel I choose. And I sometimes, well, I'll get to this in a second because we'll do a little singing hierarchy as well. After the pitch glides, I feel like if you move to inhaling the vowels now, they've had a little experience with the hum. They don't feel like it's so weird. But then you can do how, hey, hey, he, ho, ooh, ooh. And this is also a good opportunity to give them a little bit of diaphragm pelvic floor instruction and just teach them about it. If that's something you're comfortable doing, but you will be after we have our session if you're not now.
Is this where does this sort of overlap on what you do for optimal pitch?
It actually does end up revealing a more physiologic voice when you use the inhalation phonation. So the old school pitch optimization would be using aha or mm-hmm to kind of find where you just naturally go when you're doing those kind of reflexive sounds. But I find that the inhalation gets there faster. And I always felt doing the model for the patient of the mm-hmm or the aha that they would try to model my pitch, and then it wouldn't be as effective. Hold on a second. And then I would do words on the inhalation: happy, happy, hilarious, hilarious. And I usually start with H words just to move the air a little bit more, but M words also work well. And then I move to phrases. So, how are you? How are you? Who are you? Who are you? I'm tired. I'm tired, etc. I can't believe it's 8 o'clock already. I'm sorry, I'm running over. What I'm going to do, I made a YouTube video on the hierarchy of singing voice tasks for inhalation phonation. I'll send out to you guys.
Okay.
Okay.
Thank you.
And again, my apologies for asking loaded questions. My desire and my intention is to get you guys to think more critically about like what you would do in a situation if you're in front of a patient. I'm not asking, I didn't mean to ask in a way that you felt uncomfortable or that you felt like you were.
That wasn't the purpose of my statement. Just
okay. Okay. Well, I'm just also, I want you to know that I'm here totally so that I can help you become, better clinicians in general. So I do want you to think about how you would even begin to work with a patient like this. I so appreciate all of you, and I really enjoy working and sharing my experience with you. So I know I always want you to feel comfortable. Any questions?
Yes, I have a question.
Okay.
I actually, I had some muscle tension on dysphonia, and we didn't do a lot of laryngeal reposturing. We just kind of found the horns, and then sort of in circular motion sort of went down, and then did some resonant voice there, did some resonant voice, meow, 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 and did some and at the end sniff. Is that like like that? And I'm just wondering, that's like totally different from this.
That's okay. There are so many tools in your toolbox that you'll have as a voice clinician,
Mhm.
because every patient is different and every patient has things that they need. And not everyone has a high larynx, even with muscle
Right.
tension dysphonia. It's most common to see that, but it's not necessarily the case. And it's also, very clinician dependent on what they choose to do to work with muscle tension. So I'm just offering more unique techniques that are relatively new that you might not have heard about in grad school or even as a patient. So your experience is great, and obviously it helped you.
Mhm.
So you came away with a whole set of tools from that experience, and this is just another option.
Okay, thank you very much.
Absolutely.
Are you do you do semi-occluded vocal tract? Would you do that for muscle tension dysphonia?
I would, once the muscle tension is
Abated.
not necessarily fully abated, but released.
Okay.
Because if you add compression, like in a straw phonation, and you have muscle tension, it can exacerbate the muscle tension.
Okay.
So I might choose, and we'll talk about, I'm definitely going to do an SOVT night. There are ways around it if you wanted to do it sooner, but it would be a bigger straw in water. If you had, like I have a set of singing straws and they come with 3, you could do multiple straws at once. Lots of different ideas, but you do have to be careful about going to add any kind of pressure, which is why I wouldn't add like a pushing exercise where I'm leaning on the wall, increasing breath pressure at that moment when you have muscle tension, because again, it could exacerbate it.
Okay.
But what I present to you is my own perspective of exercises, and I'm sure there are so many other options out there, but these are my favorite, and so that's why I'm sharing them with you. And if you have any questions, or if you're working with singers specifically and you want a little tutorial on the singing hierarchy, I'm happy to do that with you. We can do a private Zoom.
That would be amazing.
Just reach out to me.
Thank you.
All right. Have a great night, everybody.
Thanks so
you
much,
me.
Kate.
Take care.
Thank you. That was very helpful.
Okay, good.
Thank you very much. Thanks for everybody's input, really. Thank you.
Yeah, I appreciate all of you. Okay.
Good night.
Good night.
Good night.
Bye.